Hi, everyone. We will get started in just a second. We're going to let everybody join. Hope you're having a good lunch time or lunch this afternoon. We'll give it one more minute and then we'll get started. All right, I think we will get started. Thank you all for spending your lunch time with us today. We really appreciate it. My name is Elizabeth Brewington. I am the Associate Director for Partners in Health and Wholeness, focusing on overdose response and HIV advocacy. And we are so happy to have you with us today. Partners in Health and Wholeness is an initiative of the North Carolina Council of Churches that works with faith communities to bridge health and faith together. We do this on a variety of different topics and issue areas. And I have several of my colleagues on the call today too. So if you are interested in getting more involved with us or starting your own health ministry, please connect with us. And with that, I think I should start sharing my screen and get into our topic today, which is the opioid settlement. So we are so thankful and grateful to be partnering with the North Carolina Conference and the Northern Piedmont District of the Western North Carolina Conference for this presentation. And we will kick it off. So what we will talk about today is what is the opioid settlement and what is in the Memorandum of Agreement. What options are there for counties? What can churches do? And why does this matter for our congregations? So just to set this stage and the screen and kind of give us some context about this topic, in 2019, an average of 6 North Carolinians a day died to an unintentional medication or drug overdose. We're still getting the numbers and those averages for 2020 and 2021, but on a whole, we saw about a 20% increase in overdose deaths in 2020 and in 2021. And in 2021, we passed the really grim milestone of nationally over 100,000 people dying due to an unintentional medication or drug overdose. So we are now going to shift gears and talk about the settlement. The opioid settlement has been in the news a lot recently, and it is a little misleading because you hear settlement and you think one lawsuit, and it's actually a bunch of different lawsuits. The one we are going to be talking about today is the national settlement, and that was with Johnson & Johnson, Cardinal, McKesson, and AmerisourceBergen. We're still waiting to hear how the Purdue Pharma settlement will play out. If it will play out, they're in a very complicated proceeding, but that is a different thing that will come on another day. There are also settlements still happening with CVS, Rite Aids, and Walgreens and Walmart. And last year, some money came into the General Assembly from a communications firm that had worked with Purdue that had settled its own settlement called McKinley. So there is a lot of money in terms of this opioid settlement, and it's a really big deal. Nationally, the Johnson & Johnson and Cardinal settlement is about $26 billion that is going to be doled out to all the people who signed on to the settlement over 18 years. North Carolina is one of those recipients, and we will be getting $750 million over 18 years. And they're going to front load the payments to the first 3 years to really get these programs started. And this funding is very specifically stipulated to go towards opiate use disorder, opiate abatement strategies. It has to be focused on opioids. So what is very unique about this settlement is actually 85% of the funding is going to go to local governments, your cities and your counties. Normally, North Carolina has a law that any settlement that the Attorney General brings, any money he wins, has to go to the General Assembly. This one is different. This one's going to our local communities. And so all 100 counties in North Carolina are going to receive some funding, and 17 municipalities are going to get some funding. This is all outlined in a document called the Memorandum of Agreement, and I will send a follow-up email with a bunch of different resources, including the wording of the agreement, if you're interested to see how much money your county or your city might get. I will warn you, it is a very complicated math equation. I tried for my own city in Durham, and there were a little too many decimal points for me. Basically, they have found this formula of population with the impact of the opioid crisis, and they've multiplied that together to come up with a percentage of what each county will get. Also, feel free to stop me at any point if you have questions, or you can put your questions in the chat. I'd be happy to answer any questions you might have. I will say these past slides have been from the North Carolina Association of County Commissioners and the Department of Justice, the Attorney General's office, and they did a presentation going into these details as well that is on our YouTube page, that if you would like to have some more information, I can refer you to that webinar as well. So in the Memorandum of Agreement, they have outlined two options for how the money can be spent. There are option A, which is a list of about 12 evidence-based strategies that include a number of different things that counties can invest in, or option B, which is a strategic planning process that has to include certain groups of people at the table. This means public health officials, this means faith leaders, people who use drugs and people with lived experience, all have to come together in collaboration with the county officials to decide what to do. Option A doesn't necessarily need that collaboration, but both the Attorney General and the county commissioners and us as the North Carolina Council of Churches are really encouraging cities and counties to think strategically about how to use these funds. They really are once in a generation funds that could do a lot of help for people. So as I mentioned, option A is about 12 different evidence-based options that counties can invest in, such as a strategic planning process, like I mentioned, evidence-based addiction treatment, meaning medication-assisted treatment, recovery support services, such as peer support specialists or people to help navigate after recovery, recovering housing supports, employment-related services, prevention, naloxone distribution, a post-overdose response team, a syringe exchange service, criminal justice diversion programs. These are programs that if somebody is arrested with a substance on them, they won't necessarily be detained. They can be referred to treatment or to other options instead. Making sure that there are medication-assisted treatment in jails and prisons, and reentry programs. I'm going to go a little bit behind a couple of these option A strategies and explain the evidence behind them and kind of what options are available right now in North Carolina too. So the first one is syringe exchange programs or syringe support programs. They have been legal in North Carolina since 2016. According to the CDC, a person who participates in a syringe exchange program is 5 times more likely to enter treatment for a substance use disorder and more likely to reduce or stop injecting when they use a syringe service program. Syringe service programs are also known to prevent the spread of bloodborne diseases such as HIV, hepatitis C, or hepatitis B. Currently in North Carolina, we have 38 registered syringe exchange programs and several others covering 38 registered syringe exchange programs that cover 55 counties and 1 federal tribe. So this map is a really good idea of where those areas are covered and where we are lacking syringe service programs. So if you see your county on there, maybe contact your county commissioner to talk about introducing a syringe service program to your county. Syringe service programs also offer people the Naloxone, the overdose reversal medication. They make sure people have supplies for wound care, like bandages. They really are more of a health hub for people who use drugs than just handing out sterile supplies.
I have a question. Did you say we could interrupt, or do you want us to wait to the end? Okay. So that last slide that you had on there about the statistics on the people that have access to the syringe program, that really shocked me, because I'm curious as to what would be the motivation. I full disclosure, I'm a licensed clinical addiction specialist, and I've been working with this population for decades. Mm-hmm. And I'm just curious as to what would be the motivation for someone to go into treatment, and even more curious about what would be the motivation for someone to stop injecting if they're getting clean needles. And, that just doesn't make sense to me. Do you have that information as to what the motivation is?
Yeah, so these programs really focus on meeting people where they are and working on making any positive change. So if a person is injecting drugs, maybe we'll make sure that they have sterile supplies so they won't get abscesses or bloodborne disease. And because you're in that constant conversation about and building that trusting relationship of, I'm not going to judge you for your substance use, or I'm here to help you make whatever decision and assist you as you can, people then decide, maybe I want to slow down. I don't want to use as much. And then the person at the syringe exchange program says, okay, I can help you. Or maybe I want to go into treatment. Then the syringe exchange programs have connections to all the treatment providers and can help a person navigate that system. So it's really just having that trusting relationship that allows a lot of people to stop using. And sometimes people don't, and that's okay too. But it's having that non-judgmental space to make positive changes when somebody is ready, because we know everybody's journey is different. And so.
And do you know what the majority of referrals would be if someone comes and says, I want to go into treatment and stop using? It's my thought that they're probably going to be referred to an MAT.
It totally depends on what the person wants to do. I work a lot with a syringe exchange program in Hickory and Gaston, and they have people come in all the time saying, I want an abstinence-based program. And then they have other times where people think MAT is a better fit for them. So it really is what the person wants.
Mm-hmm. Okay. I'm sorry, I'm just skeptical. I've been doing this for decades, like I said, and I'm just skeptical, but I'm open-minded. So
I appreciate you being open-minded, and yeah, I completely understand. Let's see. Yes, Jennifer in the chat said education plus relationships are very foundational. And Mary in the chat said they simply stay alive longer, so there is more of a chance for the door to treatment being open. Yes. Yes. All right. Sorry. I was just catching up my thoughts. So as I mentioned, syringe exchange programs give out Naloxone or Narcan. That is the overdose reversal medication. It is a non-addictive prescription that reverses opiate overdoses. And its distribution is associated with a 50% drop in overdose fatalities. There are a couple different kinds of Naloxone. I don't know if you can see my screen, but this is an intramuscular kind. And this one is a injectable. It is more like an EpiPen that talks to you. And then there's also a nasal spray that kind of works like an Afrin. this medication, its only job is to help reverse an overdose. So it can't be abused or cause an overdose. It only restores breathing and consciousness. It lasts for about 30 to 90 minutes. And we've had a new study that said if we wanted to drop overdose fatalities by 80%, we would need 1 kit per 100 people. And so we aren't currently getting there. There was actually a naloxone shortage during the pandemic because production had to be stopped. So we really need this medication highly available for people to really stop the overdose deaths we're seeing. North Carolina has something called a standing order, which means anybody can hold a prescription for naloxone. You can get it at your local pharmacy or your health department, but it is expensive. And so these kits can cost anywhere from $30 to, I think, $150. And so we really need to make sure that it is accessible for everyone and cost isn't a barrier. Medication-assisted treatment programs. So methadone and buprenorphine are the medications for medication-assisted treatments. They are considered the gold standard of evidence-based drug treatment. But North Carolina Department of Health and Human Services across the board has said that 80% of people who want to get treatment in North Carolina have trouble finding it for various barriers. And there are often many barriers for people being able to access methadone and buprenorphine. Oh, I got my stat wrong. It is 89% of North Carolinians are not able to access the treatment they need. These treatments are not readily available by local doctors because of strict regulations, and there are several groups advocating for lifting those restrictions right now. But with the opioid settlement money, we could really expand access to medication-assisted treatment to people. A lot of our jails and prisons do not currently offer it to people, and they're really hard to access. And so using this money towards that would be a game changer when it comes to the state of things in North Carolina. I'm going to pause there, see if there are any other questions. And Roxanne put in the chat for those interested in oh, sorry, somebody was talking.
Yes, this is Annie.
Hi, Annie.
Yes, I want to go back. You said there was one federal tribe. Mm-hmm. Which tribe is that? Do you know?
Let me go back.
Cherokee.
Cherokee, somebody said?
Cherokee.
Yes.
Thank you.
And then Roxanne also put in the chat the evidence behind syringe exchange programs. The CDC has released a guide, and she put the link to the guide in the chat if you're interested in learning more. Any other questions?
Yeah, is a 12-step program not considered evidence-based?
It is not, to my knowledge.
Okay.
One second. I'm going to try to mute the whooshing email sound. One sec. All right. All right. So what can churches do when it comes to advocating for the opioid settlement funds? First and foremost, I would highly recommend finding out what your community already has. Do you have a syringe exchange program? What treatment is provided in your community? Are there options for housing? Are there recovery supports? Connect with the local harm reduction group in your area. See what they offer, or what barriers they are facing, or what knowledge they have around the settlement. Talk to people who use drugs and people with lived experiences about what resources there are or what barriers they have faced in trying to access resources in your area. You could contact your county commissioner to see what they're planning to do with the opioid settlement funds. The county commissioners are currently learning about all these options and starting to think about how they want to use those funds. And so see what direction your county commissioners are heading. And if you want to advocate for something else, reach out and tell them. We're also going to have a sign-on letter that will go to the North Carolina County Commissioners Association to advocate for evidence-based practices around these funds, to make sure that these funds don't get misappropriated. I think I saw a hand. Glenn.
Yeah, I'd just like to add, Elizabeth, that in the various presentations like this that the state is doing, the Office of the Attorney General has been cautioning people at the county level to provide a united front to the county or the town commissioners, because otherwise they're getting frustrated with getting calls from all kinds of providers. And some of them are getting so frustrated, they're saying, I want to hear from these people. We're just going to make up our mind how we're going to spend the money. So it behooves all of the coalitions, the local coalitions or consortiums, ARCOR consortiums, to pull together, do their own little mini planning before they approach their municipality.
I completely agree. And I can connect you to other coalitions if you are interested or looking to find what coalitions already exist in your local area. Yes, I completely think having a united front on this is very important. And that's why I encourage to find out what is already available. Wendy said most counties have a point person for substance use prevention, and that can be found on the North Carolina Opioid Data Dashboard. Yes, and I will include that link in the follow-up email for those who are interested. I also have a website that lists a bunch of the local substance use coalitions and a list of all the harm reduction organizations and what counties they serve, which will all go out to you. Yes, Glenn.
Just wanted to add another thought there, that there may be a tendency of people at the municipal level who are not necessarily well-versed in the things we are to say, well, let's just put all the money in treatment. I mean, if you guys are saying it's sort of a medical problem, it's a health problem, well, let's treat it like anything else and put all of our money into treatment. And I'm worried about that, because treatment without the support of these other things that you're listing, it doesn't work. It's also extremely costly to pay for somebody's treatment. You know, one person, you're going to have to pay for a lot of people to make a difference in a community. And we do need more people in treatment. Don't get me wrong. I'm a treatment fan, but you have to create an ecosystem, a recovery-based ecosystem in your community. Treatment's a process. It's not an outcome, right? The outcome is what? Recovery, living a better life.
Yeah, I completely.
So I worry about that.
I second that, Glenn. That's my fear too, is I'm already hearing county commissioners that are like, we're going to dump all of our money in treatment programs. And a lot of the treatment programs are not evidence-based, and it very stresses me out. Like, we have one shot to get this right. And we as coalitions, as you mentioned, coalitions have to advocate for that spectrum, that prevention, harm reduction, treatment, recovery piece. If we don't do all those things, we are wasting our time. We'll be back at square one in the next 20 years.
You're going to have 8 years plus. If you don't spend all the money in 8 years, you can continue to use the money. So what's the hurry? Why put all the money in treatment right up front? It doesn't make any sense.
One of my main concerns is that this money does not go the way of the tobacco settlement money, which was very much misused and misspent. It did not go where it was authorized and supposed to go.
So there's a
Yeah.
couple things that are baked into the settlement to make this different than the tobacco settlement. It is on us as kind of citizens to make sure we pay attention to that. So all county commissioners have to pass a line item in their budget and their, not budget, I think they have to pass a county code. I'm messing up the words, I apologize. That says we are using the opioid settlement funds for this. And then there is a website that will track what each county will be using those funds for. And they have to report their metrics to that. So it is on us to make sure that those things are getting updated. It is being good, used well. It is going to things with evidence base. I also echo the fear of things getting just all the money getting dumped towards one thing, because I think it kind of, you forget about some of the other barriers that people face, like transportation or restrictive hours or lack of housing, or housing having a bunch of barriers to it. And so there are so many other aspects to this. And I think it would be too simple to just say, oh, I have a bunch of money, I put it one here, solves everything. We would have figured this out years ago if that was the case. And so I think having a spectrum of and a holistic approach to this is really going to be the way we have to move forward. Yeah. Any other comments, questions, or fears?
I wanted to, I think, follow up on what Mr. Field was saying. And I think in some ways, this is one of those places where faith communities can consider their role. So what would it look like for faith communities in different geographical areas, whether it's like at the city level or the town level, to create a supportive ecosystem? Like, what would that look like, right? If we're going to talk about different roles in different places, and we realize that, for example, medication-assisted treatment is just one aspect and just one evidence-based program. What about all the other pieces? And where would faith communities be able to help create that sort of a supportive ecosystem? And I think, for one thing, I think also education, like, what do people in faith communities think about addiction and substance use disorder, right? Like, what are their perceptions about that? And how would they be able to support people in their communities? Like, what would that look like? If they don't know the information, they're like, well, I mean, I don't know, they're addicted to drugs. So, I mean, are they even safe? Should we even have them near our church? Like, those are my husband's a pastor for a long time. So, like, those are the kinds of questions that I hear, right? When you go to a church, those people are like, yeah, I don't know that we want those people around us. So you can't create a supportive ecosystem if you're not educated. And I mean educated by knowledgeable even about substance use disorder. So that's one thing. And then I also think about, like, what would it look like for faith communities to partner with, in partnership with like providers or with even clinics, and provide the sort of social aspect of like a supportive ecosystem. The other thing I think about is sort of like, what kind of advocacy could faith communities do in like creating this supportive ecosystem to talk about economic, so it's kind of the economic aspects. And then you brought up things about like transportation and all those other pieces. So I think if we're going to have webinars like this, and we're going to have faith communities coming together, it's going to be more than just talking about the money and like, it's going to come to our county and where is it going to go? Like, if faith communities aren't ready, they're not going to be able to do anything, because they're going to be too busy figuring out, like, I don't know about this substance use disorder thing, and I don't know what we're supposed to do anyways. And so I don't want those people around here. Like, you know what I mean? Am I making sense? Like, I'm just, yeah.
Yeah. So Nicole brings up a big barrier that a bunch of people face when deciding to go to treatment or just interacting in the community, which is stigma. And so faith communities can be the ones to start eliminating stigma. We can use stigma reducing language. We can say people who use drugs versus addicts. We can really start showing kind of the love that is all in the Gospels by making sure that we aren't stigmatizing people. These are our neighbors. When Jesus was asked in the story of the Good Samaritan, who is our neighbor? Everybody in our community is our neighbor, and that includes people who use drugs. Let's see.
Yes, and if I can say something about that as well, indeed, the church has a tremendous role in reducing stigma. And one of the simple ways that we have to do it, those of us who are involved in communities of faith, who are pastoring, who are leaders, is come with the simple point that we already have persons who are recovering, in recovery, and also who are in the bondage of addiction in our congregation. This is not a matter of outside folk. The reality is that, we have members of our congregation who we love, who perhaps have been in the shadows of shame and in the shackles of secrecy and hiding because they fear of what it is to come out and talk about their lived experience. So I find that that's one of the first points for a church to really be a part of that healthy ecosystem that celebrates recovery, which is about, a process and outcomes, is saying that this is not about, to get rid of that othering. This ain't about other folk. This is about us. Mm-hmm. Because, we are the reality of people who are in need of grace. And then also there are persons, in a church who have been touched by and in need of recovery.
Thank you. Yes. I have been doing this work for the past 4 years. And one of the most powerful things I have witnessed is something we call a naming ceremony. And I'm Episcopalian, so I liken it to a prayers of the people. And it is just a simple prayer to open up space for people to name those they have lost to overdose or to the war on drugs. And every single church I've been a part of doing this naming ceremony, it starts off very quiet and then names start popping left and right. And you realize that you might have thought that you were the only person in your church dealing with something like this, and you are not. But because of stigma, we silence it. And so having things like a naming ceremony, or having a worship service around Overdose Awareness Day, or preaching a sermon on harm reduction and busting stigma, are ways we can keep this conversation going and not keep the silence, because it is so heartbreaking. I was doing a Naloxone training at a conference, and the number of people who would come up to me and just say, "Oh, my sister's struggling, my brother's struggling." They wouldn't talk to each other because we hide that away. So we really do need, as faith communities, to be this support system, but also to talk about it.
There's no reason not to think that at least one in four of your parishioners has been directly affected by substance abuse.
And
in my context, 2 in 4.
Yeah, I'm probably being conservative.
Yeah.
And so how can we offer support? Could that be a grief support group at the church? Could that be different versions of support group? NA and AA are great, but how about a harm reduction works group, or a medication assisted recovery anonymous group? There are so many different people affected by this. Can we have different options for everyone?
Or an activity-based group, such as nature or exercise, mm-hmm. or events, which are therapeutic for people with substance abuse, because it's a safe social environment that has nothing to do with drugs. So you're helping them to rebuild a safe kind of social circle again.
Yeah, there is a wonderful organization, Olive Branch Ministry. It's a faith-based harm reduction organization. and they have partnered with a church in Hickory to have a holistic harm reduction center. So that is where their syringe exchange is operated out of, but they also run support groups, but they also will have paint classes where everybody in the community has come for a paint night. So you don't know who you're sitting next to, you're just having fun and building community. That is something that church can totally do.
Yeah. They're awesome. They are awesome people there.
Yes. I will also say there are some awesome things going on in the chat, and I cannot read all of them right now. But I highly recommend taking a second to read what everybody is putting in the chat. So we're going to shift a little bit, and we're going to talk about how all of this connects to our faith, or at least you're going to get how Elizabeth connects this to her faith. I don't want to put words in your own mouth. You have your own reasons. But I connect this work and my work in harm reduction to the story of Lazarus. Michelle Mathis, who founded Olive Branch Ministry, has done a lot of work with us doing clergy breakfast, where we go out and we talk to churches and give a harm reduction 101 and connect them to resources. And she always ends her presentation with the story of Lazarus. So I'm going to copy her a little bit and retell it to you guys. Apologies in advance. I'm a Sunday school teacher, so I like doing this. So as we know, Lazarus dies, and Jesus is called and told that Lazarus is dying and he needs to come back and see his friend. But Jesus specifically waits until Lazarus has been dead for 4 days. His spirit has left his body. He is dead, dead, dead. And then he goes and he really and crucially is with Lazarus's sisters and mourns with them and fully grieves the loss of his friend. And then he goes to the tomb and he says, Lazarus, come out. Lazarus comes out. And we normally stop the story there, but I think the most important part happens next. Jesus then turns to everybody around him and says, go unbind him. Now, some people probably did not want to get close to Lazarus. I mean, he's been dead for a while. He's probably starting to smell. He was all wrapped up in those binds. So some probably just went off and told the story of, oh my goodness, this miracle happened. Jesus brought Lazarus back to life. How incredible is that? And that's great. That is where they are in this work. They are going to go spread the message far and wide, and that is great. There are other people who are going to go and get up close with Lazarus and start taking the binds off of him. There's a place for all of us in this work, and I highly recommend for you to figure out where your place is and to get involved, because we don't all need to be getting up close and binding. Some of us need to go tell the good news. And so when it comes to the opioid settlement, but also to this work in general, are you going to be the one calling county commissioners? That is great. Are you going to be the one building coalitions? That's great. Are you going to be doing a support group at your church? That is great. We all have different places that we need to be in this work. And then I just always love pointing out to people that, you know, when Jesus was performing his miracles, he met people where they were. He didn't make them come to him. And he always listened to what they needed healing. And so when thinking about this settlement, really listen to your community. Listen to the people who have been affected. Listen to the people who do this work. Listen to what they need. And then let's advocate for that. We really want to make sure that we are meeting people where they are. So finally, these are just some additional resources. There are lots more. There have been lots put in the chat that I did not have on here. And I will send this all out in a follow-up email so you will have them yourself. We have put out a Sunday school guide that is for adult Sunday school classes that walks through kind of harm reduction, the history of the war on drugs, how to get involved in this work. There is a national faith and harm reduction group that has a lot of prayers and worship resources that is amazing. The North Carolina Harm Reduction Coalition is a great advocacy resource. And then the Department of Health and Human Services, they have tons of data, tons of resources, tons of connections. Highly recommend. I will also send you out the website that has the Memorandum of Agreement on it, if you are a policy nerd and want to read all of that like I did. And I will also send out the website for tracking the opioid settlement funds and how they are used, so you can have that for your own personal resources. This is my contact info and also my colleague Nicole's contact info. So if you think of any other questions, feel free to reach out to us. But we've got about 20 minutes, so I'd be happy to take any questions that people have now too.
Elizabeth, this is Jay. Thank you so much for all of this. And we want to make sure that, can you send the link to the webinar that was held on the 10th?
Yes.
And also the recording of this one as well? Because I know there are going to be people who want to follow up.
I will do both. Yes.
So I was at one of your workshops before the pandemic, and you talked about a group of women who were knitting things. Talk about that for a minute.
Yes. So this is another olive branch story. So there is a group in Catawba County called the Catawba Crafters. They affectionately call themselves the Old Hookers, and they are a crochet group. And they, for years, had been crocheting these little washcloth patterns that they would fold in half and turn into a little bag that could be slipped onto the back of somebody's wheelchair as a little medicine bag. Well, Olive Branch Ministry approached them and said, could we use some of those bags? And could you put some little reflective yarn in it so we could put our Narcan in it and people could find it? And they said, sure, that'd be great. And so I will stop sharing and see if I can find a picture of them because they are so cool. So they did. And these bags are just incredible. They're beautiful to look at. They are, they're really life-saving because they have that reflective yarn. You can find your medication for your Narcan at night, by flashlight, by starlight, whatever, what have you. But also, Michelle has found that people would come in to the syringe exchange and say, can I have that one? That one reminds me of something my grandmother made. Or can I have that one? It's my favorite color. And it's been this way to show love to people through just an awesome project. Now, you don't never have to touch needles. You don't have to be involved with the syringe exchange program, but knitting and showing love to people. It's just a really great way to get involved. They've actually expanded and you can get the pattern online. If you're interested, I can send it to you. And so people can make these bags. They're calling it Hooking for Hope, which I like that name.
And just another example about how everybody can get involved. There's something that we can do.
Let's see. I will finally found the picture. So those are the bags. And then right at the top, that gray thread is the reflective yarn. And so one person who crocheted them made them a little big. And so now you can fit a whole syringe exchange supply in it. But they originally were this little small one that you could just put the Narcan in. Yeah.
Got a question. My name is Helen Millison, and I am the Faith Health Navigator at Randolph Health in Asheboro, North Carolina. And my husband's semi-retired United Methodist minister. We've been in the ministry over 37 years. One of the questions I have is, you mentioned peer support specialists, and I don't know too much about them, except that I hear that there's some emergency rooms that have peer support specialists in that. And what I don't know is who can supervise that? What kind of credentials does a supervisor of that have to have? Do you know that?
I don't completely. I know that a peer support specialist is somebody who's in recovery and has been in recovery for several years. And it is a special licensing and program that they go through from the state.
Right.
I don't know what the supervisor has to do. I can look into that for you though.
Oh, I'd appreciate it because, yeah, we have a program. So we have people that are trained as peer support specialists, but, you know, we're not using them here at our hospital. I feel like we could, but I need to know what the credentials are for supervising. That would be helpful.
Yeah, I will look into that.
Oh, okay. I just see in the chat. So I'd like to meet you, Jennifer.
If we could get to meet you too. Yeah, I was just telling Helen, I didn't realize who Helen was. I'm the new assistant health director here with Randolph County Public Health, and they've charged me to take on the Opioid Collaborative here in Randolph.
Wonderful.
And so we've just reconvened, and Glenn's been very kind to join us and insert new policy updates and things that are happening at the state maybe we're missing or overlooking. And we're getting ready to start work groups. So prevention work group, harm reduction work group, and connect to care work group, which covers treatment and recovery communities. And we'll be using the results-based accountability framework to build our action plans. So we're ready to build new action plans for Randolph County.
Right.
And I don't know how elected officials will use those, if they'll use those, but I know that we're trying to reconvene and really get things going again. But as it relates to peer support, a lot of times supervision can depend on the length of time that peer support person, of course, has been providing peer support services, because if they're new to peer support services, they're going to need a lot of support and a lot of guidance. I've seen that in the community. If you've had somebody that's been doing it forever and ever and ever, and they know policies and procedures really well, you know, their supervision may be minimal. And it also may depend on if you're using them in a clinical setting versus the community setting too. It really depends. We have some colleagues. I know Wendy G was here. Wendy's still here. We work really closely with some peer support folks in Stanley County, and they were used out in the community to do outreach, follow up to overdose. Also, they straddled EMS and harm reduction. We had them sharing between our EMS department and the harm reduction group, our syringe service program, and that was a beautiful partnership, because it was a bridge. It was a bridge between, EMS has encountered that person out in the field post-overdose or during an emergency, and that person builds that relationship. And, oh, I see you again at the syringe service program. It's good to see you. I'm glad to have you here. And how can I help you?
That trusting relationship. Yeah.
It works really well.
Because peer support specialists are not licensed per se. Yes, they go through 40 hours of training and they're certified, but they're not licensed mental health people. So they're not going to, the hospital is not going to be charging Medicaid or insurance for what they do. Therefore, the supervision is quite simple. It's not as complicated. And actually, they work as a warm handoff from the nurse or the physician in the ER, and they do their thing individually with the patient. But they do coordinate then with, the team, if you will, in the ER about, what would be appropriate disposition. What is that person, what's their level of readiness for treatment, or maybe it's zero, whatever. And then people that have to be seen that way in the ER, then who have to be admitted to the hospital, peer support people will follow them up to the other floors, and continue their work with them in terms of hopefully bolstering recovery toward a method of recovery. So that's a problem in hospitals, in that hospitals are not, it's not a good idea to just get one peer support person, because they quickly become overloaded with people that they want to and should follow that are admitted. So it's better to try to figure out, can we do a team of them, and they can spell each other, they can help each other. Because they get overwhelmed, they get overloaded very quickly. From firsthand information from some of them.
Elizabeth Ramos, I'm going to tell you that Elizabeth Brewington put me in touch with some of the harm reduction people in Cumberland County, and I'd be happy to share that with you.
Yes, and
Thanks, Jen.
feel free to reach out to me if you would like to be connected with people in your county. Happy to make introductions and do research and things like that.
I will send you my newsletter, Elizabeth, where I try to pin down merging and best practices. You might find it helpful.
That would be great. And Elizabeth Ramos also would like that.
Okay. Can you put your email address in the chat, Elizabeth, and make sure you get it.
Well, if we have no other questions, I will close us out with or if my colleague Nicole is still on, I might make her close us out. We have a tradition at PHW where we end with 3 deep breaths. And so I'm going to pick on Nicole and have her lead us in that.
Absolutely. So I know there were a lot of questions. I know there are different perspectives and viewpoints, and there's a lot that I think we can all learn. One of the things we hope will come out of these webinars is that we'll be able to build a group and a coalition of faith communities and clergy and laity who'll be able to partner with clinics, evidence-based programs, hospitals, providers, and help to create that supportive network for those who suffer from substance use disorder. So with that said, a PHW tradition is that we close out these webinars with what we call 3 deep breaths. We invite you to sit in your place where you are, to hold everything that we've been thinking about and hearing about, hold those things a little more loosely. You can hold your arms open, place your feet firmly on the ground, feel yourself in your seat. I think most of us are sitting, and you can close your eyes or you can keep them open. And I will count off the first deep breath, and then you can count the other 2. So if we're ready, 1. Amen.
And we will have follow-up webinars as more information is revealed and released and in concrete. We'll keep you updated, right?
Yes, we're definitely
keep us
going to be doing
updated.
that. So
There
I think
is a deadline tomorrow that the settlement that will tell us a lot when the money will come. So yes, I will keep you updated as there's more to know.
So I think maybe some really great follow-ups for some faith communities and other providers as well. Maybe might be, what are the evidence-based programs? Like what's the information behind them? How do we know they actually work? Maybe we're also thinking about a webinar about what it would look like to have kind of a supportive community in a town or in a city. That would be a collection of faith communities working together with providers, and what that could possibly look like. So those are some of the things you'd have to look forward to. And if there are other ideas that y'all have, you're the ones in your communities, right? You hear what people are saying. If you have other ideas, or maybe in your professional life, definitely reach out to Elizabeth, and we can kind of coordinate and talk and maybe kind of plan. We think this is really important. So thank you all for coming. We really appreciate it.
Thank you. Have a good rest of your day.
Thank you.
Thank you, Elizabeth. Thank you, Nicole.